periodontic with other aspect of dentistry. In this slide, we can see the caries in the cervical area of these two teeth. We need to do a crown lengthening procedure, which is a reverse bevel incision in an angle 45 degrees to the long axis of the tooth. And we do a scallop incision to cut the gingiva and doing the crown lengthening. This is also a crown lengthening for two teeth. Also a crown lengthening procedure for this central incisor. They do endodontic treatment, and we need a crown lengthening in a reverse bevel incision. You have multiple teeth. We need to do an apically reposition flap. We do remove doing a flap surgery to the area as you see, reflecting the flap, removing the bone by doing osteotomy for providing a biological width 3 millimeter, which is the best in this case. After that, we return the flap and suture it. We put a temporary crown for 7 days. After 7 days, we remove the suture, remove the crown. And after 6 months, we do the bridge after complete healing process. We have a biological consideration, aesthetic consideration, and occlusal consideration, and a special consideration for doing the gingival margin of the teeth of our restoration. The margin of the restoration should be located according to many factors. We have aesthetic concern and the need for increase the retention foam, refinement of the pre-existing margins اللي هي تحكمنا if there is root caries, cervical abrasion, and root sensitivity. The clinician is presented with the 3 options for marginal placement, either supragingival, equigingival, and subgingival location. For the supragingival marginal placement, it has the least impact on the periodontium. This margin location has been applied in non-aesthetic area due to marked contrast in color and opacity of traditional restorative material against the tooth in that time. But nowadays, with the advent of more translucent restorative materials, adhesive dentistry, and resin cement, the ability to place the supragingival margins in aesthetic area is now a reality. The advantage of the supragingival margin, the first is the preparation of the tooth and finishing of the margin is easiest. The application of the margin with impressions that can be removed past the finish line without tearing or deformation is the easiest with supragingival margin. Fit and finish of the restorative and removal of excess material is easiest. Verification of the marginal integrity of the marginal restoration is easiest. The supragingival margins are the least irritating to the periodontal tissue. The equigingival margin. It is more plaque accumulation than supragingival or subgingival margins, and therefore it results in a greater gingival inflammation. There was also a concern that any minor gingival recession would create an unsightly margin display. ممكن any recession تبين عندنا يصير عندنا فالديفرنس وكأنه يبين المارجن فرق بيناتها. These concerns are not valid today, not only because the restoration margin can be aesthetically blended with the tooth, but also because restorations can be finished easily to provide a smooth, polished interface at the gingival margin. From the periodontal point of view, the best one is the supragingival and equigingival margin. They are well tolerated by the periodontal tissue. The subgingival margin restoration consideration will frequently dictate the placement of restorative margin beneath the gingival tissue crest because of يعني احنا دائما محكومين ان نسويها subgingivally because of the caries, tooth deficiencies, على مود نسوي masking the tooth restoration interface. فاحنا مرات نكون محكومين ان نسوي subgingival margin restoration. The investigators have correlated the subgingival margin restorative انه يكون عندنا more quantitative and qualitative changes in the microflora. There is changes in the subgingival microflora, and there is increase in the plaque index, increase in the gingival index. There is recession, pocket formation, and the gingival increase of the gingival crevicular fluid secretion. The crown contour, the ideal contour, provide access for the hygiene and has fullness to great desire, to create a desired gingival form and good aesthetic. The gingival contour is very important. So we have over contouring and under contouring. The most common error in recreating the contours of the tooth in dental restoration is over contouring. هاي مشكلة عندنا. Over contouring يصير بالfacial and lingual surfaces, generally in the gingival third. Apparently, under contouring is not nearly as damaging to the gingiva as the over contouring. Convexity on facial and lingual surfaces provides protection and stimulation to the supporting structure during mastication. The buccal and lingual crown contour should be always, I said, flat, not fat, usually less than 0.5 millimeter wider than the cemento enamel junction. So remember, flat, not fat. Greater the amount of facial and lingual bulge of an artificial crown, the more plaque accumulation at the cervical margin. So take care, don't do over contour, and do it flat, not fat. The buccal and lingual surface must not they must not be over contour. The subgingival debris of the teeth all should be removed. They may be remnant from the retraction cord, the impression material, provisional material, or either temporary or permanent cement. So you should remove it after doing your preparation. Aesthetic consideration, the proximal contact and the embrasure area. For a proper proximal contact is essential to prevent food impaction. The mechanical pressure on the interdental tissue can cause, of course, ischemia, inflammation, and even necrosis of the interdental tissue. It favors also plaque growth and pocket formation. The contact point should be placed occlusally and buccally. Remember, occlusally and buccally to facilitate the access for interdental plaque control. There is locational hazard of broad contact when placed occlusogingivally. Narrow contact also is a hazard. Contact too far gingivally, contact too far occlusally, and too far buccolingually, Also, the open contact is a hazard. The ideal interproximal embrasure should house the gingival papilla without any impinging on the papilla. Also, extend the interproximal tooth contact to the top of the papilla so that no excess space exists to trap food. Any change in the shape and the form of the embrasure can change the shape and form and the height of the papilla. Too wide embrasure will cause a flattened and blunt papilla. Narrow embrasure will cause inflamed papilla. Ideal embrasure will result in a healthy and pointed papilla. How managing the gingival embrasure form for patient with gingival recession in the anterior area and the posterior area. We have a patient with a gingival embrasure with has gingival recession. How you can manage the embrasure area? Management of the gingival embrasure form. In aesthetic area, it is necessary to carry the interproximal contact apically toward the papilla. Restorations and tissue-colored ceramic can be used. In the posterior area, it is often impossible to carry the proximal contact to contact the tissue without creating a large overhangs on the restoration. The contact should be moved far enough apically. The width of the embrasure should be matched to the size of the particular interdental cleaning device recommended to the patient. There is hypersensitivity to dental materials. Many dental materials may do hypersensitivity due to not to the material restorative itself, but due to the surfaces. The surface of the restoration should be as smooth as possible to limit plaque accumulation. Also, resins are highly polishable but have deficiencies in strength and porosity and wear. Glass ceramic and porcelain veneers offer a clear advantage over any other type of restorative materials in the maintenance of good oral hygiene and good gingival health. Non-precious alloys show hypersensitive inflammatory response. Pontic design. We have many Pontic design as a saddle ridge lab, modified. Also, these are many types. Also, sanitary hygienic type. In this picture, we can see many types of Pontic designs. The sanitary, the hygienic type, the saddle or ridge lab type, modified ridge lab, and conical, egg or heart shape, and ovate form. These are everyone has advantage and disadvantage. For example, as you see, the hygienic type, it is poor aesthetic design, but it has a good access for hygiene. The patient can clean it very easily, and it is recommended for the posterior mandibular area. While for the saddle or ridge lap, it is it's somehow non-hygienic type, but it is aesthetically accepted and it is not recommended. While a modified rich lab, it is moderately easy to clean, it has a good aesthetic, and it is used in the anterior and the premolar and some maxillary molars. For the conical or egg heart shape, Pontic, it is poor aesthetic, but it has a good access for oral hygiene. It is used in molars without aesthetic requirement in the posterior area. We have the ovate type, which is it is a superior aesthetic for also it entrap food easily to clean for maxillary incisors and premolar area. For the occlusal consideration, the restoration should not be do not conform to the occlusal pattern of the mouth, because occlusal disharmony, they cause injuries to the supporting periodontal tissue. So prevent the occlusal trauma. We have anatomic considerations. There is an intimate relationship between the periodontium and the pulpal tissue. As the tooth develops, the root is formed. There is three main avenues for communication between the tooth and the supporting structure: the apical foramen, the lateral accessory canals, and the dentinal. We have many types of differential diagnosis of endoperio lesions. We have a primary endodontic disease, a primary periodontic disease, and primary endo with secondary perio, primary perio with secondary endo, and true combined lesion, which is the worst one. For a diagnosis purpose, it is very important to trace the sinus tract by using a Koteperke and X-ray. Also, it is very important to check the vitality of the teeth. And the sinus tract of endodontic origin is should be checked with the Koteperke, as I said. And whenever there is an increasing probing depth, it may refer to a periodontal problem. For a primary endodontic disease, in this X-ray we can see this is a primary endodontic. It means the pulp is the origin. The vitality test of the tooth is negative. There is, as you see, change in the widening of the periodontal ligament, and there is periapical radiolucency and in the forcation area. While after doing root canal treatment, these changes they disappear. For a primary periodontal disease origin, the patient come with multiple periodontitis. There is chronic periodontitis, not in this tooth, in other teeth also found. And it is the result of a progression of a chronic periodontitis apically along the root surface. Whenever you check the vitality of the tooth with this type, اللي هو primary periodontal origin, the tooth is vital. يعني لازم نسوي له periodontal treatment. After doing periodontal treatment, the problem is resolved. For a primary periodontal disease patient, there is a plaque accumulation, there is calculus all over the dentition. There is pocket formation and generalized pocket formation. The prognosis depends on the stage of the periodontal disease and the efficacy of periodontal treatment. For this case, in this X-ray, we can see there is apical radiolucency, widening of the periodontal ligament, there is bone loss in the X-ray. Whenever you inserted كوتابيركا هنا بالإكس-راي مثل ما تشوفين تشيكون الفيتاليتي تيست هو يطلع positive, the tooth is vital. You do a periodontal treatment and the problem is solved. For a primary endo with secondary perio, this happened with time as suppurating primary endodontic disease remain untreated. والتوث يبقى كاريز وبالبايتس وينزل البريابيكال اريا and become secondary. ومن البريابيكال اريا واللاترال canals يروح للبريودنتال tissue. Plaque forms at the gingival margin of the sinus tract and lead to plaque-induced periodontitis in this area. For a primary endo with secondary perio, مثل ما تشوفون, pathway of inflammation from the periapical area ويطلع للبريودنتال tissue lateral canals أيضا. Primary endo with secondary period treatment and prognosis are now different than those of teeth simply having endo or period disease. The tooth now requires both endo and periodontic treatment. If the endodontic treatment is adequate, the prognosis depends on the severity of plaque-induced periodontitis and يعني يعتمد على البريودنتايتس severity of periodontitis موجودة. For a primary perio with secondary endo, in this case, the apical progression of the periodontal pocket continues until the apical tissue are involved. The pulp may become necrotic as a result of infection entering via the apical foramen. In this diagram, we can see the progression of the periodontitis by way of lateral canals and through the apex to induce a secondary endodontic lesion. من اسمه primary perio يؤدي إلى secondary endo. A true combined lesion هذول يكونون سوا يعني it is formed whenever an endodontic disease progression coronally with the infection of the periodontal tissue. يعني periodontitis ده يمشي ويا البلبايتس. The degree of attachment of loss in this type هو اللي يحدد يعني severity of periodontal disease هي اللي تحدد ال prognosis of the case. مثلا إذا كان هو severe periodontally involved ممكن يكون unsavable حتى لو سوينا له endodontic treatment. True combined disease in this figure we can see تشوفون أنه نشوف أنه الاريا يعني من lateral canals to the tissue وداخل طالعة الباثوجينز. فمن this is a true combined وما نعرف من الأوريجين هل هو من البلب الأوريجين أو من البريودنتال تيشو الأوريجين. The radiograph in this radiograph shows مثل ما تشوفون bolus, horizontal bolus, severe و periapical radiolucency, التوث يعني more than 2/3 of the root with calculus present, and the clinical examination reveals also a pocket formation and the pulpal vitality من سوينا البulp vitality من شيكوها كانت negative. True combined lesion مثل ما تشوفون بهذا الاكس راي همينه bolus horizontal bolus وفوركيشن مومنت هنا نسوي لها endodontic treatment وشيكوا ايضا بالكوتابيركا اكو pocket formation يعني بريو واندو. للبريو احتاجوا للاندو احتاجوا روت كانال فولينج، للبريو احتاجوا ان يسووا لها سيرجري وفلاب وطبعا يجوز يحطون بون وجايدد تيشو ريجنريشن. هنا after a treatment endodontic treatment and combined with a periodontal treatment. Diagnosis. The data collected must be included for providing a good diagnosis is the periapical radiograph, pulpal vitality testing, percussion, palpation, pocket probing, sinus tract tracking, and نشيك أيضا الcrack tooth testing.